don't eat much. When we give them these medications, they really decrease the amount of food consumption and they do lose the weight. And actually, it's like a teaching method to them to show them what can they eat in order to lose weight. Anything beyond what they did will cause them to gain weight or not lose weight. So it's like a teaching to teach patients how much they can get away with, basically, and lose weight. Orlistat, you all know about. It creates a lot of gastrointestinal problems. It blocks the digestion of fats, and it interferes with fat-soluble vitamin. And it's now the half strength. It's available in the market as Ali. I'm sure many of you had heard about it. And it has less gastrointestinal side effect, but long-term problems is with vitamins. And the other one, sibutramine, is a meridia. I don't know if you've heard about it, but it's a centrally acting medicine. It has a cardiovascular side effect. All of them, those sympathetic activators, work on the brain and cause suppression of dietary intake, decreased dietary intake. And all of them have cardiovascular, cause tachycardia, raise blood pressure. We do EKGs for these people. We monitor them closely. And it has two means. Some of them, satiety, cause decrease in appetite, as well as it increases heat production. Topramide, I don't know if you have relatives or friends who take Topramax. It is really an anti-seizure medicine, but accidentally was found to cause weight loss. We use it sparingly, has a lot of central nervous system side effects, and it's been studied in diabetics and showed some modest, that the treatment with Topramide may induce weight loss and improve metabolic profile. So what's new also? It's the gut. This is a new concept for everybody. It's the gut talks to the brain. This is a huge thing. Everything we eat, everything we ingest, our fats, everything communicate to the brain and tell the brain, okay, I am starving, I'm eating too much, I'm eating too little, I'm consuming this. And this circuit is where all the medications and the targets that we, the things we address with our patients, because the brain actually, probably, and many of us believe, it is the center for all the weight gain and weight loss. Nice fine-tuning of the brain, chemical balance there is very important to achieve the weight loss or maintenance. There are so many medications. I don't want to bore you with these, but the endocannabinoid system, to make it simple, one of the new ones that is not approved yet in the United States, it's when people smoked pot in the past, and it's true, they feel like eating and they feel happy and increases appetite. So they found this receptor in the brain that literally it's cannabinoid receptor where if they block this receptor, people lose the appetite. So I always call it the anti-pot medications. Europe has been studied in Europe used. The only problem, it causes depression, as marijuana causes euphoria and feeling good and want to eat. This is the opposite, causes depression as well as weight loss, and that's why one of the reasons for stopping this medicine from going through. And these are the results. This causes significant weight loss. Surgical management, I'm sure many of your probably relatives, friends talk about surgical management. It is reserved for the severely obese individual, the people who have high body mass index as well as metabolic issues, and it does work. It is one of the most, it's unfortunate to say that, but it's true, it's one of the most successful ways of inducing weight loss. You can lose up to 60%, resolve diabetes completely in 77% of the people who does it, and hyperlipidemia, blood pressure, sleep apnea is where resolved in 70 to 85% of the time. 30-day mortality varies in good centers. The mortality, that's the major problem, is the short-term complications. Long-term complications mainly around vitamin deficiency and dealing with the adjustments to different diets, but really it's the short-term complications and surgical complications the main issue. Age criteria, they want people with a BMI above 40, which is called it morbidly obese patients, and or less BMI of 35 if they had other medical problems. And the bariatric surgery, as you know, it's very much rising in the United States. Even in the young adults, it tripled. Adolescents, bariatric surgery has been on the rise. So, in summary, for the weight issue or in obesity, we need a comprehensive approach. We have to do risk-benefit assessment. We individualize, we cannot generalize anything, and we include every modality possible, including diet, exercise, medication, behavioral modification, and surgery if need be in severe situations. And the most important and foremost is the education. I'm going to talk a little bit about diabetes. I'm sure all you're just too long, but I'm going to tell you a little bit about diabetes and what's new in diabetes approach. This is how we define diabetics. Is a fasting blood glucose of 126 and or 2 hours after a 75-gram ingestion of glucose, 2 hours of a 200 or above, and or if we have symptoms in the setup of a random 200 milligram glucose, which is the finger sticks that we're talking about. The pre-diabetes is a range between 100 and 126, and intolerance is between 140 to 200, and normal glycemia is below, fasting below 100, and 2 hours post meals to be 140. Three major diabetes types: type 1, type 2, and gestational. Gestational is another entity by itself and complicates 3 to 5% of the pregnancies. In type 1, we have less than 10% of the population of diabetics are type 1s, and the majority are type 2s. And just to show you that this is just to show you from the Center of Disease Control, in the US population of the 275, we have undiagnosed diabetes like 5.9 million. The diagnosed is only 1 million of type 1s. We have 10 millions diagnosed of type 2s, and additional, we have a 24.6 million with impaired glucose tolerance. And we don't do a good job. This is just to show you, it's probably, you see the thing. We don't do a good job. You see that the uncontrolled is almost 50% of the population. So we still don't do a good job for so many reasons. And it's a local epidemic. 20 million of total Americans suffers from diabetes, 41 pre-diabetes. 1/3 of these individuals are undiagnosed. An explosive epidemic of diabetes increased the prevalence between 1990, and it's even shifting to the younger population, and increased over 70% in adults between 30 to 39 years of age. And it's a major financial burden on the country. Just hospital statistics, it's the 4th most common comorbid condition identified in a hospital. In 1997, it was present only 10% in all hospital discharges. Now, almost 30% of the patients get discharged from the hospital carry the label of diabetes. Causes 2 to 4-fold increase in the rate of hospitalization itself, and it increases the length of hospital stay. And also showed that hyperglycemia in the hospital complicate numerous illnesses, and by itself is an independent risk for adverse outcome in a hospital. And it goes with BMI, as I mentioned. Until 1995, we have only few agents that we were able to use, oral agents. And we know, like most of you know, what metformin, glucophage, you have the Avandia, the Actos, and of course the sulfonylureas, the glyburide, the emerald, the glipizide, and all of these, they're only until 1995. So we came actually now a long way in the process of having new agents and new concept. And the whole concept before was, you know, around insulin. Insulin was the only thing we strive to improve, either the resistance to insulin or the production of insulin. Nowadays, we have more evidence that it's beyond insulin. Insulin is one player. There are so many hormones and peptides, these are like amino acid chains, are secreted by the gut, by the brain, by the pancreas itself. In conjunction, all of them together, they make a nice circle, or a nice circuit, I would say. Each one feeds into the other to achieve better glycemic control. Insulin is one of these hormones. And This is what's available oral medication in the United States. Sulfonylureas, usually it increases weight. It has a risk of low blood glucose and only changes 1 to 5% of your hemoglobin A1C. Metformin decreases weight, has no risk of hypoglycemia, and also it changes 1 to 5% in your hemoglobin A1C. Acarbose is the one that causes no absorption of the glucose, and therefore you get diarrhea because of the disaccharides. Has no risk of hypoglycemia, but the change in hemoglobin A1C is very modest, and because of its side effects, very few of us use it now on a regular basis. And the TZDs, which is the Avandia and Actose, they raises weight dramatically, as you heard recently. Also, there's a potential of cardiovascular risk and heart failure in patients who use it. Does not have a risk of hypoglycemia when it's used by itself, and it does a good job in terms of hemoglobin A1C reduction in 1 to 2%. This is just to repeat. This is just to show you, if we use one agent in diabetes, what are the success rate. It seems like metformin wins, and glipizides, and also Emerald, but the rest are like kind of a little bit fall behind, and therefore most of us use the sensitizer. That we're almost all of us weight oriented, and therefore we strive to use medication that cause weight loss as well as diabetes control, and give the best, like a profile, metabolic profile at the end. Insulin is the most powerful agent of controlling blood glucose level. The one drawback is, of course, the hypoglycemia and the weight gain, but it's by far the most important. We have barriers with something to do with training, upbringing. People have a big barrier against using insulin, and many people feel shy, like because they have to mix it. It's complex to start. You need education. You need nurse practitioner or a nurse to help you to start using it. And there's so many preparations now, so that confuses the patients. And the worry about hypoglycemia, and of course the worry about weight gain. So these are barriers to use it. And how to deal when, so really our duty with patients is to identify the obstacles and address them. And we also try to make the patient be in control, as well as we have to kind of talk about the benefit to their health, and talk about targets and set realistic targets, and we still have to talk about hypoglycemia, and if there's any injection phobias, if you were now using the pens instead of the vials, which by far much more easy for people to use. The easiness is beyond where you have to draw. You can carry it around in your purse, pocket, anywhere. You can use it in any place, restaurants. It's much, much easier. And of course, we address also pump therapy, because this is also easy, and people graduate to the pump, especially type 1s, although we are using it in type 2s now. So it's education about the whole process and how good it controls the sugar, and how can we tackle the problems, and what do we do in adjusting it. It's all like the health professional duty to educate the patients about this. And the pen device, as well as the pump therapy, of course, is very convenient, more accurate, less pain, makes patient more compliant, and usually it is used for a specific population, but all honesty, I think anybody can use it, and no exceptions. And it's now socially more acceptable, especially at school, and it's disposable, and not like you don't have to reuse it again, or all of that. So basically, the consensus on the treating diabetes, we have to initiate early treatment, we have to persistently titrate, achieve safety, and maintain glycemic targets, address the postprandial problems as well as fasting. People think my after meal is always good, but I wake up with 120. Yes, there are two different things. The morning fasting being high because your liver is robustly making glucose, while the post-meal is all driven, the glucose, by the pancreas, unable to achieve the glycemic control or deliver enough insulin in order for the glucose to fall down after a meal. There are two different problems. And